But good afternoon, everyone. My name's Amanda, and I'm honored to be here today. I have no disclosures to report. So let's rewind to the beginning of your training, back in residency, CA1 year, mid-July. You arrive bright and early to your OR to set up the room. The MS Maid's mantra runs through your head as you rummage through the Omnicell drawers to find exactly what you need. There's a lot going on at once. You just moved to a new state or a new hospital with a new EMR system, with people you don't know the names or titles of, and most of all, with equipment and medication you've rarely have ever used. What is a nicotine? And Robenol is part of what drug class? How am I supposed to know that TXA is supposed to be diluted into a 100 cc bag and infused over 10 minutes rather than a rapid IV push like all of our other medicines? How about on OB with Methergin? That's typically given IM, not IV like all of our other medicines. So you open up your medication drawer to find, as was previously mentioned, all of these look-alike vials. As we know, anesthesiology is a unique specialty in which we are our own sole checks and balances. On a daily basis, we have a multitude of medications readily available at our fingertips, not needing an order, pharmacy's approval, or nursing verification prior to administration. My healthcare system is a charity, small-scale community hospital in which we do not have the luxury of barcoding systems. In our Omnicell drawers, given all of these look-alike vials, they're easily mixed up. Today, I might find neostigmine in a brown bottle with a yellow cap at 0.5 milligrams per milliliter, whereas I might go to my next hospital tomorrow and find neostigmine in a clear bottle with a blue cap at 1 milligram per milliliter. So not only these different drug vial, how they appear, but also their concentrations. And again, like has already been mentioned, this has been an ongoing issue, especially because of the drug shortages. So in preparation for this talk today, I met with my patient safety officer, department chair, program director, and numerous attending anesthesiologists to give you real life scenarios of where residents can go wrong, though I was not personally involved in any of these scenarios. So first off, you're new to the OR environment and you're not up on all the hip lingo that your colleagues speak of. With this mindset, a resident was in a carotid case and was ready to reverse neuromuscular blockade with neo and glyco. But not the neo you're thinking of. The resident pushed neosynephrine. The blood pressure went to the 300s over 150s and the patient began bleeding from the carotid. This emphasizes the need to ask questions, to avoid abbreviations, and to never assume. The only assumption you can make is the fact that the person you're speaking with knows nothing. As such, this topic of level setting in teams is extremely important and something that I want to highlight, which should definitely be emphasized and facilitated more in faculty development, especially at academic institutions. So the next case is on IV fluids. I was just talking to another colleague and she says this happens at her institution as well. A trauma patient comes up to your OR in the middle of the night, almost midnight, and the patient arrives before you even have time to draw medications. An arterial line is placed and the case proceeds uneventfully. You got through the thoracotomy until you hand it off on the ICU and the ICU nurse realizes the arterial line bag is spiked with mannitol rather than normal saline. So this picture here highlights how mannitol can be with the blue font, black font, and how similar it is to our NS and LR that we typically use. Although there is no apparent harm to the patient presented, this emphasizes the need for larger system change. And hindsight proves this was a great opportunity to use the HRO principles of stop, think, review, act, and review, STAR, with each and every step that we take. So moving on to OB, the next case, we're taking a patient with a laboring epidural to C-section. We love those, right? In the OR, medications were drawn up by a chief resident and labeled appropriately. After bolusing the epidural for surgical analgesia, the patient starts seizing. Initiation of general anesthesia with intubation, followed by an ICU admission, occurred. Later, it was found that ANSEF was inadvertently bolused into the epidural rather than the lidocaine. After a root cause analysis, we no longer have loose ANSEF vials on L&D. Instead, we mitigate this with ANSEF attached to 100 cc bags, like we said TXA should be in, for infusion. Another possibility to minimize such error is to introduce non-Lure lock systems to prevent wrong site administration and minimize erroneous cross connections, especially in a place with beginner learners such as in residency. Of note, this patient made full recovery and even in fact chose to come back to our hospital for her next delivery, which was uneventful. Keeping with the OB theme, there's another medication error where a resident went to go pre-hydrate a patient and opened up the fluids wide, took it off the IV infusion pump, and heightened the IV pole. Only later did they find out that this wasn't just plain LR. It was LR mixed with Paterson. So many of these types of errors will go unreported. However, it's extremely important, as we've been speaking of, that trainees initiate conversation, be transparent and open, allowing others to learn from these medication errors so that we don't repeat them. As was mentioned, we must provide emotional peer support to those healthcare workers when errors do occur. And for the attendings in the room, I'd like you to think of how you react in a scenario when a trainee makes an error. What tactics do you employ to foster a learning environment rather than a punitive one? And I know you guys probably are doing a great job, but my attendings need to hear. So the next case scenario is in a vascular case. An older surgeon, which when talking to attendings, they were like, how did this even happen? I didn't know that was a thing. An older surgeon asked for heparin in milligrams rather than units. The resident gave the number asked for in units, and the patient got markedly underdosed and ended up thrombosing. As we know, closed loop communication is key to preventing these errors, and it could potentially have, corrected itself in real time. Heparin is notorious for these issues, given all the concentration differences listed here, and there might even be some more. A similar case, well known to pop culture, is Dennis Quaid's twins, who each received 1,000 times the recommended dose of heparin, not only once, but twice in 2007. We must also hold the pharmaceutical companies accountable as a contributing part of this problem affecting patient safety. And thus, this isn't just a resident's fault. Last case scenario, I'll run through one more case where the resident was taking care of a patient with an intracranial bleed. The attending actual program director left the room knowing that the patient was hemodynamically stable until a few minutes later, they were rushed back into the room for extreme hypertension and uncontrollable bleeding in the surgical field. Although the resident never admitted to it, they realized or hypothesized that the resident must have bolused a medication through the norepi line, even though the attending thought that that was off. This had significant patient impacts to both the patient and the surgical field. So in summary, the medication errors I just reviewed with you all lacked at least one of the 5 rights, which ensure safe medication practices. Remember, there's always a human behind each syringe. Hence why so much of this conference has been discussing ways to better prevent these errors, to ensure that we have the right patient, right drug, right dose, right route of administration, and given at the right time. So next I'll go into some factors that allow the opportunity for error to occur, especially relevant to residents. So my program we still have 24-hour shifts. We do not have a night float system. So it's been proven many times over that sleep deprivation or fatigue negatively impacts critical thinking and decision-making. In addition, nutrition, hydration, and recovery are all key components, especially in a 24-hour day, to combat cognitive performance deterioration. As was mentioned, as acute care physicians in anesthesiology, we make quick decisions at critical moments. Our scope of practice includes care during catastrophic events, such as massive hemorrhage, trauma, cardiac arrest, and devastating neurologic emergencies. On top of this, we also are typically siloed in our ORs for, if not the entire shift, which makes it very hard for in-person social connectedness within the department. Work conditions we can all relate to. This is not just relevant to residents of high stress environments, treatment complexity, lack of standardization in the ORs, lack of error alarms because we're able to bypass those soft constrictions. Drug shortages we mentioned, dim lighting in laparoscopic rooms, we just have that one clicky button. And not having the necessary drug labels. So at my institution specifically, one of our training sites, we always have the green atropine label, 0.4 milligrams per milliliter, yet that concentration is never available. It's always atropine at 0.2 milligrams per milliliter. So why is that there? Moving on to organizational culture, we have multiple training sites. We go from my program, 3 different hospitals with not only different EMR systems, but also different drug concentrations. And we have the luxury of having multiple attendings from different backgrounds and different specialties, but that means different stylistic preferences. Some like diluted opioids and some like straight from the vial, which makes it very confusing for the resident to remember if the syringes are not labeled appropriately. In addition, in a multidisciplinary OR system, that leads to hierarchical culture, which then leads to intimidation, fear of subordination, and imposter syndrome, which can discourage junior members of the team from speaking up. I'm sure we're all familiar with the production pressures, and that can get overwhelming, but should never compromise patient care. When all these competing factors, both organizational, workplace, and personal, interfere with productivity and concentration, they can have detrimental effects on patient safety and outcomes, team communication, job satisfaction, and employee well-being, just to name a few. In the interest of time, I'm not going to go into my QI project, but happy to talk about it later. This is one way that I've tried to improve patient safety at my institution, and will continue to do so happily at the implementation stage, and look forward to seeing the results. These were our top goals from the program. And ultimately, I'll leave you with this quote. I'm incredibly honored again to be here today to meet so many of colleagues that I've never met before, but also we have the same interests, and I've found so many similarities already. We know that medication errors are the leading cause of morbidity and mortality, and investigation and transparency are key to change. Work done by the APSF and all the members of this audience can break down these barriers and tackle this challenge together. As you think of your impact and spark for change, think you can pick up a mistake and carry it as a burden, or you can set it down and use it as a stepping stone for greatness. Thank you.